is better than the posterior approach or an anteversion approach. Why? Results at the end of 6 months or 12 months are almost the same. So this is my case. This is of a 30-year-old male with malignant neck of femur fracture with avascular necrosis of hip. Before we go into the surgery, let's understand how do we plan radiological planning for the DAA hip replacement. So we should see three radiological markers: femoral neck length, neck shaft angle, and the morphology of ilium before we jump into DA. So always neck length is long and is a coxa valga hip is always better for a DA because this will allow good workspace within the joint for acetabular preparation as well as femoral stem insertion. So coxa valga hip is always better. Second thing that you see is the ilium to ischium ratio. So if ilium is long, it's a wide pelvis, it will hinder in the femoral stem preparation. So we have to be careful about this kind of pelvis. These are known as the Mickey Mouse kind of pelvis. In these pelvis, DA should not be preferred approach. Also, I would not recommend to start off with hemi replacements or neck of femur fractures with severe osteoporosis. These cases, there are high chance of fracturing as well as there are sometimes FFDs at the knee. So the femoral extension in the with malignant neck of femur with avian, GT should be at the level of the break of the table. So that when you go for a hyperextension, the hyperextension happens with the femoral level. Secondly, I always have a CM on the opposite side that helps me with acetabular reaming preparation as well as femoral and acetabular sizing. Second thing is to prepare paint and drape both the legs. Usually bilateral TKR drapes help you with them, and this is also helpful for bilateral simultaneous avian cases. Incision is usually a 7 to 10 centimeter incision that starts 2 centimeter inferior and lateral to the anterior superior iliac spine, and it is extended towards the towards the fibula. It is curved towards the fibula. So that is the incision for DA. Then as a superficial dissection, we have to identify Sartorius and the tensor fascia lata. So this is the video. This shows this is the Sartorius muscle. This is Sartorius. This is where the nerve is, and this is the tensor fascia lata. So how do you identify tensor fascia lata? It is violet in color, and we should go through the tensor fascia lata. This is a modified Hutter's approach, so that goes through the split of the tensor fascia lata. It is very easy earlier to go in. Once you go through the tensor fascia lata, there's again a layer. This is the layer of the rectus sheath. Here there's a good color coding. There's red on the top, yellow and white. You have to go between yellow and white so as to reflect the rectus sheath. After this, the rectus is reflected in the front, and what you see are the lateral circumflex vessels. These are very important. It is very important to ligate them, cauterize them, because these are the cause of postoperative bleeding. So once you take down the rectus sheath, rectus is retracted anteriorly. You get to the femoral neck. There is a vestigious muscle over the femoral neck that is known as the iliocapsularis. So this muscle has to be erased, and then we directly reach to the femoral neck. At the femoral neck, we have to do an I-shaped or H-shaped capsulotomy. In earlier cases, you can do a capsulectomy. So this is how we do it. This is how we expose the neck. There are two spikes, one superior, one inferior, and one over the acetabular. And then we do a capsulectomy or capsulotomy. So this is the neck exposure. After this comes the neck cut. So neck cut is very important. It is very important to take neck cuts under the CM guidance like this. And it is always better to rotate the femur internally in order to take the neck cut. Sometimes while taking the neck cut, if we have not kept the femur in internal rotation, if it is in neutral external rotation, we can directly cut over the greater trochanter. So that is a mess. So always keep the femur neck cut, or sometimes you can also do in situ osteotomy and remove it, like a napkin ring osteotomy also you can do, but a neck cut is usually enough. And then you have to subluxate the femur out of subluxate the femoral head out of the acetabular. So this can be done with the help of corkscrew. The corkscrew should be inserted in superolateral part of the femoral head, where it will have the maximum purchase. And then we have to, so the acetabular preparation is quite different from what we do through the posterior approach. The anteversion as well as inclination is entirely different than what we do for a posterior. So as I've shown in this video, be somewhere here at around 20 degrees of anteversion and as close to the body as possible. That takes care of the inclination. So that is acetabular anteversion and inclination. You can ream and check under the Siam where you are going. Are you going high or are you going low? And that is the beauty of direct anti approach. You can place the acetabular component under the Siam guidance. So this was my final acetabular preparation. You can see good bleeding all around. And then we do the middle cup impaction. We have to note that the screws are somewhere here. Screw heads are somewhere here in the superior portion. So in this case, I got a very good primary cup fixation. But for the demonstration purpose, I am showing how do you insert the screws. So it is very easy to insert the screws. We can rim it, and we can see in the Siam where the screws are going. In such case, we can measure the amount of screw, and some people have reported that they can put longer screws and multiple screws into the acetabular. So this screw insertion also becomes very, very easy. After this, the liner insertion is done. This is what I've impacted the liner. Then comes the femoral preparation. Now, acetabular preparation is comparatively easy, but the challenge with direct anti wherein you will put the spike and cause hyperextension of femur. So this is how the position is, and you have to put a spike between abductors and the rotators that will cause elevation of femur. Then we do broaching and entry. The entry should be done as anterior as possible. Like when we are doing posterior approaches, we tend to take entry from here. But in DA, we have to take entry from the anterior cortex as much as possible. Then we lateralize the stem as a usual femoral preparation. And then we insert the trial stem. To judge the anteversion of stem is very easy. You have to just be parallel to the posterior cortex. This is the posterior cortex and this is the anterior cortex. You have to be just parallel to the posterior cortex, and that takes care of all the form of anteversion. So this is how we put the trial stem. This is my final stem. You can see we don't need any table for hyperextension. We can do it on a regular potty table as well. This is my final stem. This is the head. We impacted the head also. For reduction of this head, we have to do traction and interrotation so the head pops up into the stump. So this was my final fixation. As you can see, the good anteversion inclination and a good stem purchase, which gives good purchase distally as well as a proximal purchase. Practical step is to avoid inadvertent femoral canalosis GT fracture. I usually do reaming of femur with flexible reamers. This is how we check the stability: full flexion, squat position, good stability, rotations, and one thing that you have to check is something known as extension and external rotation. So in extension and external rotation, if it is not dislocating, it means it's a very good and very stable head. You can check the limb length during the surgery itself. As you can see here, that limb lengths are very good and equal, and that judgment is done intraoperatively only. This is what is the progression of learning curve. You can start with low BMI, low mass patients with long valgus neck, then increase muscle mass, then varus neck, then you can go to dysplasia, deformity or bone loss. This is the learning curve. So take home message: it's an excellent approach. No need for many fancy gadgets, but has a steep learning curve. Pre-op planning and case selection is very, very critical. I would recommend that ideal candidate would be a young, thin female with coxa valga hip and a good bone structure. Thank you.